Okay, fine. Should I start?
Yes, sir.
Okay, fine. So, good evening, everyone. As a continuation of our web lectures, today I'm discussing hematological abnormality and Down syndrome. In short, you can say hence hematological abnormality in Down syndrome. This is a very peculiar group of hematological abnormality that is to Down syndrome. So here we will discuss few of the normal abnormalities, and another is a abnormal abnormality which really require a treatment. So I am Dr. Pankaj. I am a senior consultant at National Cancer Institute, Nagpur. To So, as you all know, how we diagnose the Down syndrome morphologically as well as by doing a karyotyping. So, it is caused by an extra whole or partial copy of a chromosome 21 and is the most common chromosomal abnormality in the live newborn, approximately 1 in 644 to 733 births. So, what are the clinical features? All you know this. They may have a mental retardation, they have characteristic facies, congenital heart disease, gastrointestinal abnormalities, and hematological abnormalities. So we will today discuss various hematological abnormalities in the Down syndrome. Morphologically or phenotypically, they have a broad flat face, slanting eyes, epicanthalite fold, short nose, short and broad hands, small and arched palate, big wrinkled tongue, dental abnormalities. So any combination of like these abnormality can be there. There may be a congenital heart disease, PS, pulmonary stenosis, or VSD, ventricular septal defect. They may have a big toes widely spaced, sandal gap, diminished muscle tone, and they can present with any sort of intestinal blockade, and many loops on fingertips, palm crease, growth failure, mental retardation, flat back of the head, abnormal ears. So all we know these morphological features. By these morphological feature, we worked up for to know whether he is having some abnormalities or not. So before going to the hematological abnormality in Down syndrome, hence, I would like to discuss a case of Down syndrome who's having a abnormal hematological findings. This is a real case scenario, though I have changed a few of the specification to hide the um, identity of the patient. So it's only a few days back, actually, it's a month or 2 months back, I got a call from my pediatrician friend. So he had a one unit of 10 days old. He presented with the pallor, actress is there. He was a tachycardic. There is a respiratory distress requiring oxygen support and hepatosplenomegaly and also having the ascites. So they have ruled out, I think, torch, neonatal sepsis, and other. But simultaneously, as a routine, they have done a lab workup, and what they found, there is a hyperleukocytosis. You can find there is 82,500 counts, and hematocrit is a little bit increased. Platelet count is a 150. That was normal peripheral, but this is the most important finding. This smear is showing 68% blast, and there is a little bit raised SGOT, SGPD. LDH is very high, 2,880. Uric acid was 7.8. PT was 63.9. APTT was 73. And fibronin is less than 35 milligram per deciliter. So at this time of point, they called me because he's having abnormal cells on a peripheral smear. So in that background, he had given me the history that child is having a Down syndrome. They have sent the karyotyping before. And then at this point of time, when he called me actually at day 15 or day 16, so we know that the child is having a Down syndrome with this sort of a clinical as well as the hematological finding. What I did, I asked them to send the sample for the flow cytometry, and this was the flow cytometry. So here you can see the different colors. The red colors is the blast. They are a dim CD45 positive, and you can see there is a lot of blast in the peripheral blood, and that turned out to be a myeloblastic features with the, so that is sort of look like of a myeloblast M7 sort of AML. But at this time point, because child was very, it's a new units only. So we labeled it as a transient myeloproliferative disorder. We also worked up little more. That is, there was a normal cytogenetic for AML, but the GATA1 mutation, which is very peculiar to Down syndrome and transient myeloproliferative disorder or AML with Down syndrome, we found that was a positive. That was a later on we found, because it take some time to get this report, GATA1 report. But at this point of time, we know that we are dealing with the transient myeloproliferative disorder in Down syndrome child. So he was a dyspneic. They did a X-ray chest and it was a pleural effusion. They have aspirated the fluid till I got the call. And when I got the call, what I did, so I asked them to handle all these situations. And then because of the hyperleukocytosis, he has a features of a tumor lysis syndrome. So we manage that. Rasberry is a very good drug for the hyperuricemia. Hydration is the most important part to treat the tumor lysis syndrome, whether it's a Down syndrome or whether it is a other cause, other background, in other background. But if you think child is having a tumor lysis syndrome is defined maybe biochemically or clinically. Biochemically means when uric acid is more than 25% of baseline, phosphate is raised, and calcium may or may not raise, but it may be decreased even, because calcium phosphate deposit in the kidney and cause the renal failure. So this way, tumor and uric acid definitely is increased, and potassium can be increased. So they are the some features of the tumor lysis syndrome. Clinically, they may have the seizure or there is a cardiac arrhythmia and may lead to the death if you don't intervene earlier. Other thing is that because of, they may have the low platelet, this child is not having a low platelet count, but they may have thrombocytopenia, so there is a chance of bleeding is there. So what we did a treatment of hyperleukocytosis by hydration and TLS by tumor lysis syndrome by giving the rasburicase, later on put on a xyluric acid. And they did a repeated pleural effusion treatment. He was symptomatic. Actually, we will see later on what are the treatment for this Downs when they have this transient myeloproliferative disorder. Different name has been given: transient leukemia, transient myeloproliferative disorder, or TAM. That is a transient abnormal leukocytosis. So, what is the treatment if they are symptomatic? That he's having hepatomegaly with a deranged liver function. He's having a, most importantly, he's having a pleural effusion for which he needs a repeated tap. So I started with the low cytarabine, and he responded to this treatment. And then later on, we were able to discharge him, and now he's on a follow-up. And yesterday, a CBC was normal, and we asked them to come in the next month with the CBC and all, whatever the required investigation. So coming to the this hematological abnormality in Down syndrome, they may have a neutrophilia. 80% chance, 80% of the patient may have the neutrophilia. They may have the thrombocytopenia or polycythemia. They may have the transient myeloproliferative disorder, which we have seen in the last patient, and they may develop the acute myeloid leukemia or the acute lymphoblastic leukemia. So we'll see how the pathogenesis of the TMD or AML or ALL is there, how they develop all this thing. So in depending on the age, you can diagnose actually. So as I said, he was a neonate in this last patient. So we labeled as a transient myeloproliferative disorder, also known as a transient abnormal myelopoiesis TAM or transient leukemia. Non-specific changes: neutropenia, thrombocytopenia, increased peripheral blood nucleated red cells, and polycythemia, abnormal myeloid cell granulation, giant platelet. In infant and children, they may develop the acute myeloid leukemia. Mostly, they are the M7 megakaryoblast, or they may have the myelodysplasia, or they have acute lymphoblastic leukemia. So, hematological abnormality in hands are mild, clinical course is benign, and spontaneous by the 3 weeks of age. But what they have the chance of developing later on a AML, that is the AML-DS in Down syndrome. So first come to the details of the transient myeloproliferative disorder. TMD is a disease entity unique to Down syndrome, we want, and is defined as a morphologic detection of the blast in Down syndrome less than 3 months of age. As I said, they have a 3 name: transient myeloproliferative disorder, TAM, transient abnormal myelopoiesis, and transient leukemia. Spontaneous resolved by the 3 months of age. You need not to worry if they are having a they're not having a much complications, then they resolve by this thing, and nothing is needed actually. We have a few years back, say one child or units with all this features suggestive for TMD, but he is not having a clinical features like ascites, pleural effusion, pericardial effusion, or in distress. So we managed her conservatively and did nothing actually, and he's now 3.5 years old. So uh, coming to the what clinical features of TMD, as we saw in last units, they may have the pericardial pulmonary edema. They may have a hepatosplenomegaly, more of a hepatomegaly, because at this time the liver is the hematopoietic organ, and they may develop hepatic fibrosis. This is the dreaded complications, and they may have obstructive jaundice. There may be a liver failure or ascites. In hematological wise, if we see leukocytosis there, abnormal platelet count reduced or raised. Reduced platelet shows a poor prognosis. Hemoglobin may be reduced, raised to normal, and increased peripheral blood blast. Other are the skin rash you may find. You may or may not find this thing. So this is what you should, when and what you should do. So this is they defined in a low risk transient myeloproliferative disorder, intermediate risk TMD, and high risk TMD. 40% in low risk and intermediate risk, but high risk maybe you may find it in 20% of the patients. So what are the clinical features of low risk? They may not have a hepatomegaly or hepatomegaly without liver dysfunction or no life-threatening complication, as what we had in last child, that he was having a respiratory distress. So what is the therapy? You observe only and they subside the hyperleukocytosis, or the count become normal in a due course of time. In intermediate risk, that may be also in a 40% of the patient, they may have a hepatomegaly plus evidence of a non-life-threatening hepatic dysfunction, significantly elevated AST, ALT, or bilirubin, no life-threatening complication, strongly concerned, very low dose cytarabine, that is 0.15 mg per kg for 5 to 7 days. In a high-risk patient, cardiorespiratory compromise may be there, maybe pericardial pleural effusion, hyperleukocytosis, hepatomegaly, life-threatening hepatic dysfunction. Then you have to take care of each and every part. As I said, if they have a hyperleukocytosis, you have your therapy should be directed to treat the hyperleukocytosis, and other like we were repeatedly tap the child, and you must give the aggressive supportive care, and very low dose cytarabine therapy is indicated in these children. We will see why we need a low dose cytarabine therapy in this. So this is the pathogenesis of hematopoiesis or abnormal hematopoiesis in a Down syndrome if they develop the TMD or AML or ALL. So how they develop? So there is expansion of a fetal liver progenitor cells, and there is a window of opportunity for GATA1 mutation. GATA1 mutation is a very characteristic for a AML-DS or TMD in Down syndrome patients. So in this figure, you can see the transient leukemia arises from an expanded fetal liver progenitor as a result of constitutional trisomy 21, providing a window of opportunity for occurrence of acquired mutation in the hematopoietic transcription factor GATA1. So in most cases, what had happened? The spontaneously they actually resolves. So TL, transient leukomogenesis, spontaneously disappears, but some children may need treatment, like who develop ascites, cardiorespiratory distress, and so on, so on. Most of the time they resolve by themselves, but 20% of the children of this TMD may subsequently develop the AML. So this is the pathophysiology of developing either a TMD or myeloid leukemia in Down syndrome children. That is why we need a close follow-up. And if we see the bone marrow, not a bone marrow, even a peripheral slide, so what you will find, there is a megakaryoblast in TMD, and as well as the acute megakaryocytic leukemia, large size megakaryoblast with irregular nuclei and moderate pale blue cytoplasm resembling the myeloblast. And this is very characteristic, typically megakaryoblast morphology, the cytoplasmic projection and tiny isophilic platelet granules. You can see in this picture. So here is this megakaryoblast. Now, there is a difference between the AML of Down syndrome and AML without Down syndrome. So what are the differences? Most important difference, what actually it is not written here, is the sensitivity to the chemotherapy. AML-DS are very chemosensitive as compared to AML. Other are AML-DS present in less than 5-year age group. AML mostly more than a 5-year age group. Present in count in AML-DS may be low. It is not a TMD where you are finding a high count. It is a here developed acute myeloid leukemia. So we have found a low count in AML without DS. There may be a normal or high. Meningeal involvement is rare in AML DS, but may be involved in AML. Incidence AM7 is the most common in AML. Anywhere you can find meningeal to AM7. Cytoabnormality is less frequent, as we have seen in last, but in AML common, like NPM1 or CKIT, FLT3 ITD. Other abnormalities are more common with the AML without Down syndrome. GATA1 is a very characteristic of AML DS or TMD rather than a AML without Down syndrome. So what protocol we use for a myeloid leukemia, Down syndrome? It's a BFM, Berlin or a German protocol is there, Berlin Frankfurt Munich protocol 98. So here, actually, when we see in a few next slides that they are very sensitive blast of Down syndrome patients, so they need a very low dose of chemotherapy. So if you see, if we give a 41 gram to 47 gram per meter square to non-Down syndrome patient with AML, here only 28 gram per meter square is sufficient. And anthracycline, if you give 320 to normal patient without Down syndrome, here 230 is sufficient. So Down syndrome patient will not receive maintenance. In BFM 98, the maintenance is there. Other protocol don't have a maintenance therapy, but they say in Down syndrome, especially don't give the maintenance. No need for a cranial radiation, no stem cell transplant. We will see what good results are there. So why we are reducing the dose? Well, because they are very hypersensitive to various chemotherapy like cytarabine 12 folds, anthracycline 2 to 7 folds, midostaurin 9 fold, and etoposide 20 fold, busulfan 5 fold, vincristine 23 fold. So you have to decrease those doses in case of AML to decrease the toxicity, and it has been seen that even if you decrease the dose, the outcome will not affect in AML particularly, not in ALL. Okay, so these are the few outcomes from various group. So if you do NOFO trial, NOFO trial that was in between 1984 to 2001, you can see excellent outcome, 74%. If you see the children cancer group, CCG group, there is a 79% overall survival, 5-year-old survival, which is against the normal patient with AML, where you expect around 60 to 65% of the 60-65% outcome. 3-year OS for 67 children treated with the AML BF 98. As you can see, the 91%, and together these data confirm a favorable outcome for Down syndrome patient who develop the myeloid leukemias. Why? So we'll see one example is there for a CYTARBINE, for an increased expression level of the cytokinin beta synthase gene, which is located in chromosome 21. That is why if this enzyme increase, they are highly sensitive to the low dose cytarabine. Their impact of the GATA1 on cytidine deaminase level and cytarabine sensitivity. ALL patient have same sensitivity for chemotherapy as non-DS patient with leukemia. So how much dose can you reduce? For example, ARAC, you can 10 milligram per meter square is sufficient. So it's a BD dose for 7 days. VCR, it is actually normal dose of VCR is 1.5 milligram per meter square. So you have to reduce by 2/3. Same with the retinyl palmitate. So on. So dose reduction 75% and 16% of anthracyclines and cytarabine, which are the main drug for any AML patient, specifically which do not influence the relapse rate in those patients. So here you need a low dose, and without you are compromising the outcome. But what is the difference in acute lymphoblastic leukemia and Down syndrome? There was no significant difference between DS and Down syndrome and non-DS ALL patient in MRD-based risk group assignment, nor in day 15 marrow response or in anti-leukemic efficacy between DS and non-DS ALL. But toxicity is high. So dose-related toxicity mortality is high in this subgroup. It is so that is why here, if you compromise the dose, outcome is actually you are compromising with the outcome as well. Drugs, what are the main drug toxicities? Mucositis, infection rate, altered methotrexate pharmacokinetics. So there is a reduced folate carrier on the chromosome 21. There are increased chances of the cardiotoxicity because of the anthracycline induced. Now we'll see this is the driver mutation, GATA1 mutation, GATA1S mutation, which is responsible for hypersensitivity and leukomogenesis in case of a Down syndrome. So GATA1 is a double gene finger DNA binding transcription factor on X chromosome. So disease specific, role in promoting specification and terminal maturation of myeloid progenitor cells to red cells and megakaryocytes. Expression of the mutated GATA1 protein GATA1S in embryonic and fetal megakaryocyte progenitor result in excessive megakaryocyte proliferation and to a lesser extent the abnormal differentiation. So this is the figure. Here we can see that this is a whole sequence of the GATA1. You can find the 6 exons there. There is genomic DNA and wild type protein in GATA1S and so on is there. Terminal truncated protein. Mutation in GATA1 in myeloid leukemia with Down syndrome and transient leukemogenesis. The GATA1 gene is composed of a 6 exon with non-coding and coding 2 translation start site uh, are present on exon 2, the other in exon 3. Protein translated from the second ATG GATA1S lacks the first 84 amino acids. Mutation in TL and ML DS are principally in exon 2 and 3 and introduce stop codon in the first 84 amino acid or abrogative splicing of exon 2 and 3. Why it is important actually whenever we ask to send the flow cytometry of these transient leukemia or AMLDS, we must ask them to do the GATA1 because that is a driving mutation and it will you will be sure that you are going to use a low dose chemotherapy for AMLDS patients. And as we know, for a transient leukemogenesis, you have to do the workup, whereas the GATA1 is necessary to diagnose the transient leukemia or a transient myeloproliferative disorder in background of a Down syndrome. So what is what conclusion of this presentation is there? So hence the benign hematological condition with some self-limiting abnormalities, but TMD resolved by 3 months of age. Symptomatic patient may require treatment. As we have seen, there is a 3 classification or 3 risk stratification. So low risk, intermediate risk, and high risk definitely, and intermediate risk need a low dose chemotherapy. Why they need a low dose? Because they are very chemosensitive, and out of them 20 to 30% may progress to AML. So you need a close follow-up. And AML disease DS is highly chemosensitive. ALL DS sensitivity is same as non-ALL DS, but increased toxicity. So this should be in our mind. Whenever you have a kid, I will summarize that patient again. So the neonate presenting with the ascites, presenting with the pleural effusion, and fortunately we have the CBC, and the peripheral smear is the most important part. Whenever we are suspecting the hematological disorder, you have to do the peripheral smear. There you find the blast, then you call the hemato-oncologist, then we run a flow. We got a diagnosis of the something is a megakaryoblast is there, but he was a Down syndrome baby, so we thought it may be a transient myeloproliferative disorder. We did a GATA1 that comes positive, but we have not waited for the result because it's symptomatic. We started on the low dose CYTARBINE, and he has shown a very good response along with the management of the tumor lysis syndrome. So I think this will help you whenever you see such sort of a baby suspected with Down syndrome and some hematological malignancies or hematological abnormalities. Thank you for your patience hearing. I'm open for your questions.
Thank you, sir. I believe it is one of the most important and very frightening complication in Down syndrome.
Right.
And like you mentioned, if have a proper knowledge, this is one aspect in Down syndrome patient we will have better understanding and how to take care of them.
Right.
Thank you.
Definitely.
Thanks a lot, sir. I
Anyone else?
haven't received any questions yet, sir.